Good afternoon, everyone. We'll get started. The topic today is a huge topic, coronary CT. And I thought I will break it down into past, present, and future. And my goal is to really give you all a good appreciation of the key CT literature that most of us should know with regards to coronary CT. A lot of it is very bread and butter stuff that we talk about every day. So the past, we're going to go over some landmark trials in cardiac CT. We will go over where the technology stands at present, and then very exciting future developments in coronary CT that I will talk in the later part of my talk. I have no disclosures. So this is the format and the topics that I will be covering, so a lot to cover here. So starting with the basic thing, which is the appropriate use criteria, which, as you know, is there for all modalities. So this is the ACC, AHA, SECT appropriate use criteria for coronary CT. What you need to know is what is appropriate and what is inappropriate. They score the indications from 1 to 9, and 7 to 9 score is appropriate, and 1 to 3 is inappropriate. And in general, coronary CT is appropriate in patients with low to intermediate risk of coronary artery disease. Here's a table that can help you assess the pretest probability of CAD in a patient, but most of you are very good at doing this clinically and don't really have to look at a table. So starting with the most frequent indication, which is symptomatic patients that are low and intermediate pretest probability, CT gets an A for that, appropriate. These are patients with normal EKG and cardiac biomarkers, so we don't do coronary CT on patients who have active ischemic EKG changes or positive troponins, or if they have a non-diagnostic EKG, so whatever makes you think they are in the low to intermediate risk category, not high. So it gets a U for high. And I, they're inappropriate if someone is actually ruling in for a non-STEMI. One thing I'd like to point out is if someone is very low risk, younger patient, the guidelines at least prefer that we do treadmill stress test. But if that is not possible, then CT can be appropriate. For evaluation of coronary arteries post-heart transplant, it gets a 6 and a U. If you are seeing somebody with a newly diagnosed cardiomyopathy with depression in left ventricular ejection fraction, we can refer them for cardiac cath, but CT is equally good to rule out coronary artery disease. It's appropriate to do it for coronary evaluation before non-cardiac surgery in an intermediate risk patient. Some indications in EP, NSVT, and syncope, you want to rule out CAD. You can do it. It doesn't get an A, but a U for those. And this is type 2 MI. We see a lot of this, elevated troponin, but without any evidence of this being a type 1 MI, so it gets a U for that. CT in the setting of prior test results, that's an important one. If you have equivocal results from a stress testing modality, or discrepancy between the EKG or the imaging findings, it gets appropriate for that. Someone who's had prior stress tests, but they're having new or worsening symptoms, it is appropriate to do CT for that. Evaluation of graft patency after CABG, and I'll have a couple of slides about that later on. That's appropriate. Stents, if they are more than 3 millimeters, are appropriate, but increasingly we are evaluating stents that are less than 3 millimeters. We'll talk about stents later on as well. So I talked about these landmark trials when I gave this talk last year as well. I'm going to make this shorter because we're going to talk more about future directions towards the end. And the 3 landmark trials that I listed were the ROMICAT, the PROMISE, and the SCOT-HEART. The SCOT-HEART is an important one because you'll see a lot of the later slides that talk about new technology. A lot of that new technology has actually utilized the data from the SCOT-HEART trial to see how that technology works, because they have data for outcomes in those patients for over 5 years. So the ROMICAT-2 at this point is an old study from New England Journal of Medicine 2012. This was, there was a ROMICAT-1, then ROMICAT-2, which was a multi-center trial looking at the utility of coronary CT and in an emergency room setting in acute chest pain patients to see if incorporating a strategy using coronary CT is going to be a more efficient way of triaging these patients. It was a multi-center trial, and the primary endpoint was length of hospital stay with some secondary endpoints, including rates of discharge from the ER, major adverse cardiac events just up to 28 days, and the costs. Length of hospital stay, which was the primary endpoint, was significantly reduced by about 7.8 hours in the CT group versus the standard evaluation. That makes sense. Negative predictive value of CT is excellent. It's normal. You send them home. Time to diagnosis were shorter, so more efficient use of resources, 10 hours versus 18.7 hours. The major adverse cardiac events were similar, not statistically significantly different. We already went over these. So PROMISE was looking at the utility of coronary CT in an outpatient setting. This trial was published in 2015, also in New England Journal. Symptomatic patients were randomized to a strategy of initial anatomical testing with a coronary CT or initial functional testing, which could have been a stress echo, a plain exercise treadmill EKG, or a nuclear stress test. Most of these patients presented with symptoms of dyspnea or shortness of breath, and their composite endpoint was death, MI, hospitalization for unstable angina or major procedural complication, and median follow-up was up to 25 months. And there was no statistically significant difference in the primary endpoint in the two groups. So that's shown here as well in these Kaplan-Meier curves. So their conclusion, which was kind of stated in a odd way, was that a strategy that involves anatomical testing with CT did not improve clinical outcomes over a median follow-up of 2 years, but at least it was comparable. It wasn't worse. Now moving on to Scott-Hart trial. This trial was published around the same time in Lancet in 2015. This is from Scotland, and this is different because these patients were chest pain patients. They have these specialty chest pain cardiology clinics in Scotland, and so these patients were specifically referred to these clinics for evaluation for suspected angina, and their primary endpoint is very interesting. It was certainty of the diagnosis of angina secondary to coronary heart disease at 6 weeks. So these patients from these cardiology clinics, 12 chest pain centers across Scotland, were randomly assigned to standard of care plus CTA or just the standard of care. Big study, about 2,000 patients in each arm. And at 6 weeks, they showed that CTA reclassified the diagnosis of coronary artery disease in 27% of patients and diagnosis of angina due to CAD in 23% of patients. So this table is a little bit hard to interpret, but just focus on what I have highlighted here as red. So this is, for example, standard of care plus CT. At baseline, there were 7% of patients where the clinicians thought at baseline there was possible CAD, but after the CT, they said yes. But there are no such patients in this group that did not get a CT. Similarly, looking at diagnosis of angina due to coronary artery disease, they said probable, unlikely in 3% and 2% of patients, and then that ended up being yes after CT was done. So obviously, CTA increased the certainty of diagnosis of angina due to CAD, and because when you do CT, you see plaque, you can't ignore it, so more of the patients that were in the CT arm were started on treatments, preventive treatments, anti-anginal treatments. So the initial Scott-Hart showed that at a median follow-up of 1.7 years, there was a 38% reduction in major adverse cardiac events, fatal and non-fatal MI, but it wasn't statistically significant. So that's where their 5-year follow-up comes up, which is very, very strong data. That was in New England Journal 2018. So this has a median duration of follow-up of 4.8 years from this trial, primary endpoint being death from coronary artery disease or non-fatal MI. And here they were able to show that there was a statistically significant difference in their primary endpoint, standard care versus the standard care plus CTA arm. This is standard care. This is CTA. Here's the cumulative incidence of the primary endpoint, which was 2.3% in the in the CT group versus 3.9% in the non-CT group with a hazard ratio of 0.59. In the initial Scott Hart trial, they mentioned that the rates of invasive coronary angiography were higher in the CT group. That's been shown in multiple studies in the past as well, because we do call lesions, we do overcall lesions, at least with the current technology. But they actually showed that at 5 years, those differences kind of were not there. So at 5 years, there was a similar rate of invasive coronary angiography in the standard of care versus the standard of care plus CT group. So the conclusion is very strong from this follow-up data that use of CT in addition to standard of care results in a significantly lower rate of death from CAD or non-fatal MI at 5 years, without resulting in a significantly high rate of coronary angiography or coronary revascularization. All right, so those were the three landmark trials I wanted to talk about. We're going to move on to the present CT-derived FFR, which is now the standard of care. We all use it. And I just want to talk for the next 5 minutes about CT FFR and the future developments that are happening in this area. So the parameters that affect FFR are the degree of stenosis in a coronary artery, the size of the coronary arteries, and the myocardial mass that is supplied by the stenosed artery. Right now, the only FDA-approved vendor for that is HeartFlow, and they use an algorithm that involves an integration of computational fluid dynamics with anatomical data from CTA to create these three-dimensional pressure maps that are then color-coded, and then we can put a cursor anywhere and look at what the CT FFR value is along the coronary tree. It gets complicated. What's behind these computations is something called Navier-Stokes differential equations, which are based on mass and mass conservation and momentum balance. So these are all the things that are going on behind the scenes: coronary artery segmentation, quantification of flow, microvascular resistance. These are all those Navier-Stokes differential equations, and eventually this is what we're getting. There have been many studies that have validated CT FFR versus the gold standard, which is FFR done invasively in the cath lab. This is an interesting study that looked at the diagnostic performance of FFR CT when compared to our other stress testing modalities, namely SPECT, PET, and just coronary CT alone without information of FFR CT. This is a very unique study. It was a sub-study of the Pacific trial, and they have 208 patients, but all these patients had a coronary CT, a SPECT, a PET, and an invasive cath for the FFR done to the same patient. So probably not a study that anybody can do again. And the diagnostic performance was then compared using invasively made FFR in the cath lab, less than 0.8 being the reference standard. And here are the AUC curves, and you can see they do it on the per vessel basis and the per patient basis. On the per vessel basis, CT combined with information from FFR CT had the best AUC, followed by PET. This is CT alone, and this is SPECT. Now, when they did the per patient analysis, PET was slightly better than CT plus FFR CT, and then here CT alone, and here their SPECT. So the conclusion was that FFR CT showed higher diagnostic performance than just CT by itself, SPECT and PET on a vessel-based analysis, and PET had a slightly favorable performance in this patient-based analysis. These are numerous studies that have looked at the specificity and accuracy of CT-FFR, comparing it against the invasive CT-FFR as the gold standard. And you can see the accuracy ranges in these is mostly in the 70s to 80s in most of these studies.
I have a question. So if CT-FFR is this good and even almost superior to PET, in high-risk patients, why do you use PET? Would it be easier to, or wouldn't it make more sense to use CT with FFR?
Well, we can't do CT on everybody, so we're going to come to one big indication where we send for PET, which is patients with very high calcium scores, where the CT is not going to be interpreted. So frequently we are sending those patients to PET, or if there is another reason, they have contrast allergy or something that they cannot get a PET, or if there is information needed for microvascular ischemia because there's quantification of blood flow. So, there's a lot of other reasons to choose PET. All right, so this is a study that's relatively recent, published in 2023. And I find the study interesting because this was one of the first studies that's looked at how in current day and age, the FFRCT can be a gatekeeper to the cath lab. So this was done by the same group who did the PROMISE trial, and they did this study where they randomized subjects to either a precision strategy, what they call, or usual testing, and the aim of the study was to see if this precision study improves the clinical efficiency. It was a big trial, randomized clinical trial with median duration of follow-up duration of almost a year at 65 North American and European sites. These are all patients with stable symptoms of chest pain. So they were stratified into the two arms based on the PROMISE minimal risk score. I won't go over it, but this is a risk score that was derived from the PROMISE data, from the PROMISE study. And this trial, which they call the PRECISE trial, these 2,100 patients were randomized either to this precision strategy or usual testing. And then within the precision strategy, if the PROMISE risk score was low, testing was deferred. If this was elevated, they elected to go for coronary CT with FFRCT for any lesion that was 30 to 90%. And the composite primary endpoint was safety, death or non-fatal MI, or clinical efficacy, which is a rate of false positives, in other words, invasive cath without obstructive CAD. And they were able to show a statistically significant difference in their primary endpoint, but it wasn't driven by the safety. It was all driven by invasive cardiac cath without obstructive coronary artery disease. And the whole argument is that in the past, all the studies have shown that CT, at least initially in the first year, leads to more invasive caths. This is the first study that's showing that actually less patients ended up in the cath lab, and the ones that did end up in the cath lab actually did have significant disease. And the reason for that is that they utilize CT FFR. So a lot of lesions that we would have sent to the cath lab if they're normal CT FFR were not sent to the cath lab. These are the CT FFR values and the number of patients who had them. It highlights the role of FFRCT as a gatekeeper to the cath lab, and they mentioned in the discussion that unlike trials of CT alone, the precision strategy in the PRECISE trial reduced unnecessary diagnostic caths, probably because of the utilization of CT FFR. Just briefly, FFRCT can be used. This one paper looked at its utility in complicated CAD. These are patients with 3-vessel disease, and this was part of the Centex 3 Revolution trial. And they provided the heart teams with FFRCT results and another heart team without FFRCT results. And incorporation of FFRCT resulted in reclassification of 14% of patients from intermediate and high risk to a low syntax score tertile. And with regards to decision whether it was going to be multi-vessel PCI or CABG, they elected, it changed that decision in about 20% of patients. There is also this technology available, which is a CT revascularization planner tool, which can predict post-procedure coronary flow dynamics. This is helpful for the interventional cardiologist, so this is not routinely used right now, but this is probably in future going to become more prevalent in CT labs. So here's, for example, a lesion with low CT FFR values beyond this point, and it's basically modeling what the FFR CT values are going to be post-stent placement. which can help with procedural planning. Some key consideration of FFRCT, it does assume that nitroglycerin has been administered. Generally speaking, about 4 to 10% of the exams are returned because of suboptimal quality. In patients with stents, you can still do FFRCT for the non-stented vessels. And then we'll talk about these newer approaches. So that's where the future is. So right now, we just have heart flow with computational fluid dynamic derived CT-FFR, but these newer approaches called anatomically derived CT-FFR are being developed. And here is one study looking at one algorithm that has come up with this machine learning-based CT-FFR. So the argument is that the CT-FFR using computational fluid dynamics is computationally demanding. It has to go to heart flow. It has to come back to us. And these newer versions of CT-FFR, which are based purely on three-dimensional anatomy, can be just done on your desktop with the click of a button on just a regular workstation. So this study looked at 351 patients at 5 centers in US, Europe, and Asia. And when you develop any machine learning model, you have to train the model. It's not magic, and you train the model by feeding it the ground truth. So what was the ground truth? So they fed this machine algorithm 12,000 3D coronary models of various anatomy and degree of stenosis, for which the computational fluid dynamic CT-FFR values were enabled. So what the machine is learning is, if the anatomy is a certain way, what is the CT-FFR that heart flow will give us? So it's trying to predict that based on an anatomy. It gets very complicated. This model is based on 28 input features. And there was very good correlation between the machine learning based and computational fluid dynamic based CT-FFR, with a correlation coefficient of 0.997. The machine learning CT-FFR also has very good correlation with invasive FFR. And here is the ROC curves for using FFR less than 0.8 in the cath lab as the gold standard. As you can see, both of these FFR CTs, from the traditional one from the computational fluid dynamics, as well as this newer one, machine learning anatomical based one, have similar AUCs. And so when we talk to the vendors that are coming in the space, clearly is one big one. They'll say we also give you the ischemia score. There are multiple vendors. I'll show a slide for that. And what is that ischemia score? That ischemia score is based on one of these anatomical machine learning algorithm derived CT-FFR. All right, CT in the setting of high calcium score, we deal with that every day, especially the CT fellows here know all about this. This is a nice study that from Cedars-Sinai that looked at patients who had a calcium score of more than 1,000 and had a coronary CT done as well as an invasive cardiac cath within 90 days of each other. Median calcium score very high in this study, 1,616. So they looked at a total of 119 patients. So as you know, overestimation on CT is the frequent problem. So here are all these examples in A, B, C, and D of overestimation. These were called significant lesions, and on cath, all these 4 lesions are not significant. But underestimation is actually also possible. Here a lesion that was cleared on CT, but actually was a tight lesion on cath, and here's another one. And their primary outcome was a vessel-based agreement between coronary CT and invasive cath, using a stenosis of greater than 70% as significant stenosis. So the negative predictive value if remains excellent, both on a per vessel or a per patient basis, even in patients with high calcium score. But what suffers is your accuracy and the positive predictive value. Look at the positive predictive value, 45% and 63%. On a per patient analysis, there were 30 patients that had that were false positives, so they were called as significant on CT, and cath did not show that, but there were also those 3 examples of 3 false negatives. This is just showing you that it also depends how the calcium is distributed. If the calcium this is not a stent, this is just calcium distributed linearly along this LED, and you're able to clear this. But if you have big chunks of calcium, that's a problem. You cannot read through this. But you should not go ahead and proceed doing CT on patients with very high calcium score, because this is going to be the exception. This is going to be the more frequent scenario. Moving on to cardiac CT with stents. In the chest pain guidelines, generally functional testing is preferred for evaluation of chest pain in patients with prior stents. The challenges that are present in stent evaluation on coronary CT include beam hardening artifact, volume averaging related to the stent struts. Frequently, there's superimposed calcified plaque that limits the visualization of the lumen. And these patients usually have a lot of calcium and CAD in the non-stented segments as well. Sometimes there are calcified plaques right before or after the stent, and all these things make interpretation difficult. As I mentioned, AUC criteria says that if they're more than 3 millimeters in diameter, they're okay for evaluation by CT. This is a meta-analysis of 35 studies involving 2,600 patients that looked at the sensitivity and specificity of 64-slice CT for detection of in-stent restenosis, defined as in-stent restenosis greater than 50% on invasive cath. Excellent sensitivity and specificity if done in the right population, good positive and negative likelihood ratios. The accuracy and the sensitivity is reduced if the stent strut thickness is more than 100 micrometer. These days, most current generation drug-eluting stents have a thickness that's less than that. If the stent diameter is less than 3, if they're bifurcation stents, if the heart rate is fast, even in a thin patient, we try to use 120 kV for stents. We use the sharp filter, and very thin slice reconstructions help. This is just example of in-stent restenosis. This is from our lab, and you can see this hypotenuated area correlates with what they found in the cath lab. This is an example of a patent stent. A few words about CT with bypass grafts. So that gets an A in the AUC guidelines. This is a study that looked at the meta-analysis of 2,482 grafts from multiple studies and compared the diagnostic performance of CT to invasive cath in these patients with prior CABG. And you can see the grafts are, they don't develop, they are big structures, they don't develop a lot of calcification typically. So most of the time we are pretty accurate when we say the graft is patent. Now the native arteries in those patients, of course, is a different story. So the sensitivity and specificity are excellent, AUC of 0.99 in this meta-analysis, and the accuracy is excellent regardless of the graft conduct type, namely whether it's arterial versus venous. One thing to keep in mind is that if graft patency is the primary goal of the study, coronary CT is clearly appropriate. But if evaluation of native coronary arteries, and we get a lot of these recs where there's a progression of, not just for graft, a progression of native coronary artery disease, that is much harder because calcium score is going to be typically high in these patients, excluding the areas of stents. And functional testing, such as PET, may be a better way to go in those patients. Just examples of graphs, how they look. This is the touchdown side, Lima to LAD, and SVG going to an OM branch, and this is the SVG headed to a PDA. All right, let's talk about photon counting CT, which is getting installed in the Smith Tower or OPC Tower as we speak. All right, so what is photon counting CT? You guys have all heard the name. Just to go over the physics briefly, when we say the tube voltage on the scanner is set at 80 kV or 140 kV, that doesn't mean that's the only kV of the photons that are coming out of the scanner. There is actually a wide spectrum. It just means that the majority are going to have an energy of 80 kV or 140 kV, whatever you've sent the tube voltage at. This is comparing the detectors that we have right now. They are called EID, or energy integrating detectors. So EID is the term you're going to see more and more mentioned in studies, and this is the photon counting detector. So just to recap, in our current CT scanners, there are septa that separate these bins. So how narrow these septa can be together is what's going to limit our spatial resolution, because at some point, if you keep putting in more septa, the efficiency of the system goes down. So when a photon strikes this scintillation detector, light signal is generated, which is then converted to an electrical signal. And all the signals that are striking between these two septa are basically averaged to generate this electrical signal. That's why it's called energy integrating detector. In the photon counting detector, the reason the spatial resolution is so much higher is because there are no septa. You're not limited by that, and each individual photon that is striking, directly striking the anode, generates its own current, which is proportional to the energy of the photon that's striking it. And so this is not a photodiode, so there's no conversion of the photon energy into light here. The machine can separate the energy of the photons in different bins, so it can look at, for example, how many photons are striking that are between 50 and 100 kV. And this information allows one to do something called spectral imaging. I won't go into the details for that. That's a whole talk in itself. And this is just showing that because of the lack of the septa, the detector pixel size is much smaller in the EID detectors. So spectral imaging, just so that you know, that's based on the energy information of the different photons, can lead to better stenosis grading, reduced contrast dose, and you can actually generate non-contrast scans from contrast scan by eliminating iodine. This is the real advantage of the photon counting CT, high spatial resolution. These are all the things that we're looking for when we read coronaries: improved small vessel imaging, less blooming from calcium, improved stent imaging, and improved visualization of plaque characteristics, leading to increased diagnostic confidence. Siemens is not the only one with the photon counting CT. All the major vendors have their own versions of the photon counting CT. Siemens was the first one that was installed for patients at EMC, which is, I believe, in Netherlands. And they use different detector material. And Siemens, of course, has the patent on the dual source technology, so there is the dual source scanner. This was the first report on 14 participants with coronary artery disease that underwent CT with both systems at that hospital in Netherlands. That was the first one in the world to get it. Photon counting CT and EID CT. This is from Radiology 2022, and they just show these representative pictures showing us how the photon counting CT is superior. First of all, notice the matrix is not 512 by 512, it's 1024, because your slice thickness is down to 0.25 millimeters. EID CT is 512 matrix, usually our slice thickness is around 0.6. And here's a non-calcified plaque. Yes, you can appreciate it, but here you can actually see clearly where the boundary of where this non-calcified plaque is ending. Here's an example of a stent with a little bit of calcification outside the stent struts. You can't really appreciate it on our usual scanner. This is an example of a mixed plaque visualized on the photon counting CT, just much better resolution than on the usual EID CT. This is one lesion that they show in their example where on photon counting CT, the reader said lumen was clearly visible. So lumen is much more clear. As with this picture is not bad, but some of the readers said there was maybe significant stenosis. And this is just from last week. Dr. Pasha shared this over the weekend with us. This is from, I believe, the group at San Francis Hospital in Long Island. They were the first one in the US to get the photon counting CT, so they already have data. a lot of data with it, and they recruited, in this study, they looked at about 7,800 patients between 2022 to 2023 who underwent either a photon counting CT or a EID CT, and they have, I think, both Toshiba and GE over there for their EID CTs. And patients who underwent the photon counting CT were less frequently referred to cardiac cath lab because it's supposed to be more accurate, 9.9% versus 13.1% with the older scanners. And among those who were referred to cath, revascularization was more frequently performed in the group that had photon counting CT done, meaning that these were true lesions, not false positives. And the specificity, positive predictive value, and diagnostic accuracy is all better with photon counting CT. Sensitivity 98% versus 93, positive predictive value 83% versus 63%. So this is the big improvement because that's what we struggle with when the calcium score is very high. All right, so switching gears, we're gonna spend a couple of minutes talking about the CAD-RAD system of reporting. It stands for Coronary Artery Disease Reporting and Data System. This was created to standardize the reporting system for patients undergoing coronary CT, and then also to guide possible next steps in management. The first CAD-RAD was published in 2016. Revised CAD-RAD was published in 2022. The stenosis grading is the same between the two. The plaque burden grading was not there in the 2016 version. Now they rate the plaque as P1 to P4, which is basically mild, moderate, severe. And there are two new modifiers. One is I for ischemia, which is based on the CT-FFR information, and one is E for some exceptions that I will show you. And the term vulnerable plaque has been replaced by HRP, which stands for high-risk plaque. So degree of stenosis categories didn't change. This is how we read it. Minimal stenosis, mild up to 49%, moderate up to 69%, and then above that is significant. This is the classification of the plaques, P1 to P4, which is mild, moderate, severe, and extensive. And these are the modifiers. I is the ischemia with if the FFRCT is abnormal, and then E are some exceptions that pathologies you can pick up on coronary CT, including coronary dissection, anomalous erosions, aneurysms, pseudoaneurysms, fistulas, vasculitis, and so forth. And then I don't think we use this, but in the paper they do have these tables depending on your CAD-RAD score, 0 to 5. So 5 is when you have severe stenosis. There are guidelines as to how to manage these patients, and there are two tables, one for stable chest pain and one for acute chest pain, but I think we all know how to do that clinically without looking at those tables. All right, moving on to a next area, which is a very interesting area today with a lot of new technology coming in this arena, which is plaque characterization on coronary CT. This is one of the first seminal papers that was published in this area from Dr. Motoyama and Jack in 2007, and they looked at plaques in patients with acute coronary syndrome and in patients with stable angina. And it wasn't a big study. I think it was about 40 patients in each group. And they looked at these characteristics of plaque, positive remodeling, vessel remodeling, non-calcified plaque, which was either low attenuation plaque, Hansfeld units less than 30 Hansfeld units, or more of a fibrofatty plaque, 30 to 150 Hansfeld units, and spotty or large calcifications. And the features that were associated, which is true even today, of the plaques that are associated with ACS are positive remodeling, low attenuation plaque, meaning Hansfeld units less than 30, and spotty calcification. So this is now called HRP, large necrotic core burden, that gives you that very low Hansfeld units. Positive remodeling, which it's not just growing outwards, there is a definition for it, which is based on the remodeling index, which is the lesion diameter by reference diameter. So positive remodeling is thought to be there if the diameter at the plaque site is at least 10% greater than the do these plaque features correlate with outcome? And this is where data from Scott Hart comes back. So this was a post hoc analysis of Scott Hart trial. And at this point, we have multiple vendors that have these semi-automated way of generating plaque volumes and the types of different kinds of plaque. So I think this is the AutoPlaque software, which is out of Cedars-Sinai. This has coded red as these non-calcified plaques, and this orange as these low attenuation plaque. And when they looked, because the outcome data is available from the Scott Hart trial, they found that the low attenuation plaque burden was the strongest predictor of myocardial infarction with a hazard ratio of 1.6, irrespective of cardiovascular risk score, coronary artery calcium score, or the degree of coronary artery stenosis. This is a very important and interesting study by Dr. Narula that really has informed a change in our thinking of how to think about what plaques are vulnerable, because we've always thought that the vulnerable plaques usually are not causing significant stenosis. They could be just 20, 30, 40% plaques. But this data has shown that actually plaque progression is one of the necessary steps for eventual ACS. So they looked at around 3,000 patients for the presence of high-risk plaque features and stenosis greater than 70%. And then they had data with the serial CT in 449 of these patients. And what they found was that the plaque progression was an independent predictor of ACS. If you look here, high-risk positive versus high-risk negative, of course, there is higher event rate, but just the plaque progression by itself also predicts irrespective of the kind of plaque. So this has led to a change in thinking, which is it really true that most ACS result from the rupture of mildly stenotic plaque? Because CT data have confirmed that lesions that do not progress rarely lead to ACS events, regardless of the extent of luminal stenosis or baseline high-risk plaque morphology. That's what the study was showing that I just showed. So that tells us that plaque progression is a necessary step between early uncomplicated atherosclerosis and plaque rupture. So, preventive treatments should be aimed at regressing this plaque over time. And we will be able to follow this over time in future, because our standard CT reporting is going to give plaque volume and also subcategories of what kind of plaque has grown or has remained stable. This is a nice review from Michelle Williams' group talking about a plaque characterization on coronary CT, and they emphasize the move from qualitative to quantitative coronary plaque analysis. As I mentioned, there are a lot of softwares available for that. And what all these softwares are doing they are looking at the boundary between the coronary lumen and the vessel wall or the surface of the atherosclerotic plaque. And then they're looking at the boundary between the outer vessel wall and the epicardial flat. And the plaque volume is defined as the volume that's between the lumen and the outer wall boundaries. These are all the vendors in the space currently. Clearly is one. We're doing some work with Lucid. Their product is called Veview Cap. AutoPlaque, that has been used in a couple of studies that I showed you from Cedars-Sinai. But basically, this is what all of these are doing, some semi-automated way of quantifying the different kinds of plaque. All right, do we have normative data? If we're going to start reporting this on our CT reports in future, do we have normative data on plaque volumes? And we just got it this year. This is a study from 2024 in JACC Cardiovascular Imaging from Dr. Lipsick's group. They looked at quantitative plaque assessment in 11,000 plus patients from 29 healthcare systems in US and Canada. And they used the fully automated QI/QCPA, which is from HeartFlow, for plaque quantification, and they have given us these nomograms. These are the percentiles based on age and gender and what your plaque volume is, so that you can look that up and see where the percentiles stands. And this is an important thing. We already knew this. This data is confirming this, that younger patients exhibit a higher prevalence of non-calcified plaque. So when you look at patients less than 45 years of age, This is women, and these are men with non-calcified plaque. So it's a much higher proportion of non-calcified plaque versus in older patients, this proportion is basically the same. This was how a future report is going to look like, which is going to look at stenosis reporting, plaque characterization, CT-FFR, not necessarily using the computational fluid dynamic CT-FFR, but using one of those anatomical CT-FFRs. This is a sample of a report from Clearly, for example. This is, I'm going to actually skip the study because we already went over one machine algorithm. I'm going to focus on radiomics. So one step further to just plaque characterization is this field of radiomics. And radiomic, what is radiomics? It's defined as using quantitative parameters like shape, intensity, and texture to extract information from medical images. So this is information that is not visible to our eye. The software is able to extract thousands of such features from images, and the aim is to enable precision phenotyping. This study, published in 2022 in JACC Imaging, looked at a radiomics-based precision phenotyping to identify plaques that are causing acute coronary events. So they know from prior data that attenuation-based plaque measures on coronary CT have demonstrated prognostic value for patient-level risk of coronary events. And so they hypothesized that beyond these conventional parameters, there may exist latent morphological plaque features that are not captured by the current coronary CT analysis techniques. The software is able to generate these heat maps, and that heat maps are basically clusters of different radiomic features. And the format of the study is similar to that original study I showed you from Dr. Motoyama, which looked at 40 patients with AC and 40 patients with stable angina. They looked at 60 patients with acute MI that had coronary CT done before going to the cardiac cath lab and matched them to 60 outpatients with stable CAD. They were able to show that a model that incorporates not just plaque features. So this blue line here is a model that's incorporating high-risk plaque features, plaque volume, and features from radiomics associated with high plaques that are associated with ACS, and that has the best AUC for discriminating culprit lesions causing MI. In this model, there is ranking of features in the final machine learning model. Most of these are radiomic features, some are high-risk plaque features, some are quantitative plaque features, so these are color-coded. Radiomic features are the pink ones, and then quantitative plaque features are the dark blue ones. I'll skip that. So moving on to the last part of my talk, which is FAI, you guys must have heard, or Fat Attenuation Index. So as you know, atherosclerosis is all about inflammation. Dr. Peter Libby has pioneered this work, and this is just a review showing the interplay of the different cytokines in the vessel wall and how inflammation is leading to atherosclerosis. So this is the thinking behind using perivascular fat attenuation index, which is an imaging marker of coronary inflammation. So if you have a lot of inflammation in the vessel wall, the cytokines are released from the inflamed coronary artery, and they diffuse to the perivascular adipose tissue, where they cause inhibition of the locoadipogenesis. So as the fat cells die, that's going to shift the Hounsfield units to a more positive value. Fat typically has Hounsfield unit around -190, and that's going to shift to a value closer to 0 if your FAI index is high. So this is the study that really started this field in Lancet. It's called the CRISP CT study, where they looked at perivascular fat attenuation index in the proximal RCA, proximal LRD, and proximal left circumflex. Now, what is perivascular fat? It's defined as fat which is within a radial distance equal to the diameter of the vessel. And in this study, they had a derivation cohort from a hospital in Germany, and the validation cohort, which were patients at Cleveland Clinic. And they were able to come up with this cutoff of greater than 70 Hounsfield units, and showed that high perivascular FAI values using a cutoff of greater than -70 are an indicator of increased cardiac mortality. They came up with this cutoff using the derivation cohort, but then it was validated in the validation cohort. And this review basically talks about how perivascular fat is not just there to support the vessel wall or cushion it. It has an active profile of its own cytokines, and there is a crosstalk between the fat cells in the perivascular tissue and the vessel wall, and that regulates a number of things, including vascular tone, nitric oxide coupling, endothelial cell activation, vascular smooth muscle migration, inflammation, all of those things. And conversely, cytokines going back into the fat cell are contributing to differences in the rates of fibrosis, edema, lipid accumulation, and lipid differentiation. So this basically highlights that a perivascular adipose tissue that is inflamed, as measured by the fat attenuation index, could be a therapeutic marker beyond high-risk plaque features on CT and beyond significant stenosis on CT. And CT can be a one-stop shop which can look at all of those things. Now we're talking plaque characterization, degree of stenosis, FFR CT, maybe anatomical FFR CTs in futures, and then FAI index. This work is all done by a group in the UK at Oxford. And now they have formed a company called Caristo, where they'll take a CT and run it through their software. It'll give you these pictures of the fat attenuation index along the vessel walls. And actually, there are percentiles available for what your score is. So these are the different vessels: LAD, left circumflex, and RCA, the FII score, and where it falls in the percentile. All right, the last part of my talk, this is just the last two slides. This is, are we ever going to get to a point where coronary CT is used for primary prevention? This is from Dr. Michelle William and Dr. Newby. Dr. Michelle William was actually the one that's the first author on the Scott Hart trial. And they talk about the rationale for using coronary CT in some patients, maybe not all patients, for primary prevention. And I know Dr. Nasser is not here, but it's the power of zero. We had that talk on rounds one day. Calcium score is a good rule-in, but not rule-out, especially in younger patients. I showed you the data from this year from Dr. Lipsick showing that patients less than 45 years of age are more likely to have non-calcified plaques. And these are some of the things that they talk about in their review. For example, in the MESA study, 1/3 of events occurred in patients with calcium score of 0. In the coronary artery calcium consortium cohorts, 43% of patients with cardiovascular death had a calcium score of 0. And there is another database called the Cardiac Coronary Artery Risk Development in Young Adults that's showing that calcium score of 0 is more likely in younger patients, which is what was just shown in Dr. Lipsick's paper. So the argument for CT for primary prevention is stronger than before, at least if you're younger and you have at least one big risk factor like diabetes. This is a field in progress because we have all these tools at our disposal now, advanced plaque analysis with all those softwares, fat attenuation index, and radiomics. There is a trial that has already started called Scott Hart 2, which is looking at doing CTs for primary prevention in asymptomatic patients with at least risk factors. I think the majority of the patients in this study are going to have diabetes. But this is just a matter of time. This field is going to expand. The technology is going to get better, and hopefully radiation doses come down even further. And with that, we will end. Thank you for your attention. Any questions? No? All right, that was a lot of stuff. So I think it's recorded, so go back, listen to it, and know all these studies, because these are really all the key studies you need to know in the field of cardiac CT. Okay? All right, thank you guys.